Welcome to part 3, the occupational therapy process, chapter 10. The information in this chapter is from your Solomon and O'Brien textbook, and we are going to be talking about legitimate tools, purposeful activity, activity analysis, adapting and grading activities and configuring them, therapeutic self, and goal writing, as well as reevaluation and discharge planning. I'm including this slide from part 2 into this section just as a quick review. When we engage in intervention plannings, we consider the parent's concerns and the child's concerns, strengths and weaknesses, what is the potential of the child, long-term and short-term objectives, how are we going to address this? We've already talked about how frames of reference can tease out our method, media, and modality, and the frequency and duration of treatment. So don't be alarmed that this isn't in your PowerPoint slide order. It's just a duplication of this slide. Your textbook talks about legitimate tools, and what are these? These are the tools, our toolkit, the tools in our bag that we as a profession use. And they are used to bring about change. So, to facilitate change, right? That's the whole purpose of intervention. What we do know is legitimate tools can change over time. Why would they change over time? Well, we're a dynamic profession. We want to use tools that are based on the best evidence, knowledge of the profession. Technology is changing all the time, so our tools will change. And we also consider the needs and values of both the profession and society. So, what are some of our tools as practitioners? First thing, we use occupations. We use purposeful activity, activity analysis, activity synthesis, therapeutic use of self, and these are all legitimate tools that we work into our intervention plan. Occupation. I'm not going to spend a long time on this slide. We know that the goal of OT is to help kids participate in their desired occupations. When we think of kids, we think of education, we think of socialization, we think of play and leisure, and rest and sleep. IADLs. So what do? We analyze the occupations. We're masters of activity analysis, right? So we're going to analyze the occupations. We're going to find the areas that there's a glitch in. We're going to remediate the deficits to assist a child to be able to engage in the occupation. We talked about a variety of frames of reference. We might use a different frame of reference, such as a compensatory strategy or an adaptive technique from the rehabilitative frame of reference. Or we might use a sensory integration approach. Regardless, we're going to remediate the deficit, and all our activities, all our interventions are occupation based. They have a purpose for the child to engage in occupation. And we know per theory that it's really important that kids engage in the actual occupation. And the text gives an example. An intervention to improve a child's ability to play with others may consist of inviting another child to a therapy session or a sibling to facilitate play. Purposeful activities are defined as goal directed behaviors and that constitute occupations. That's directly from your text. An activity is purposeful if the individual is doing it voluntarily, if they are an active participant, and it's really directed towards a goal that is meaningful to the individual. We can use these purposeful activities to evaluate, to facilitate, to restore, or even maintain function. The focus is on the process, not necessarily the outcome. What happens when someone's engaged in a purposeful activity? They feel good about it. They develop a sense of mastery and competence. And activities occur within a context. So, in an environment that the individual does these activities, for lack of a better way of explaining it, let me just read it from the text so I'm more clear. Purposeful activities occur within the context of personal, cultural, physical, and other environmental conditions and require a variety of client factors. What could some of the client factors be? Neuromusculoskeletal, um, mental functions, and body systems. So, purposeful activities are unique to an individual, right? And we grade or adapt them specifically for an individual. Purposeful activities, they have a purpose, they're meaningful, we use them, and we focus on the process, not necessarily the outcome. Activity analysis. Earlier, I said we are masters at activity analysis, and you have done this and will continue to do this throughout your professional engagement. So, what is activity analysis? It's the process of analyzing an activity to determine how and when it should be used with a client. It involves the identification of the components or client factors necessary to perform an activity. So, if we think of buttoning an open front shirt, think of the components of client factors needed to do that: bilateral integration, in hand manipulation skills, visual skills, right? Lots of client factors. And there are several types of activity analysis, and we're going to discuss two types that the textbook explains, and they are task focused activity analysis and child and family focused activity analyses. And we're going to look at those on the next slides. On this slide, we're going to talk about task focused activity analysis. And we're going to, in this approach, identify activities using the physical, which is the sensory motor, the cognitive, and social emotional components that are involved in a task. And we use activity analysis. We're going to describe the materials for the activity. We're going to look at the sequential steps of the activity. And very importantly, we're going to look at the safety concerns. Task focused analysis, practitioners are going to think of: how is the activity graded? How can it be adapted? What kind of factors, personal, cultural, level of skill, are impacting, or meaning of this activity, are impacting engagement in this activity? So if this is not a meaningful activity, is the client going to be the child going to be really invested in doing it? I don't think so. So we have to think of that. How can we use this activity therapeutically? And what are the activity demands? So on the next slide, I have the task focused activity analysis uh, demonstration illustration from figure 10.8 in your book. It's on page 169. You can see it on the screen, but if you want to see it bigger, you might want to turn to page 169. If you want to follow along, or if you want to look at it in a large view, please turn to page 169 of your textbook. This task focused activity analysis. I am not going to read all the details on the sheet because you can do that, but you can see here is the activity description. So the activity that they're analyzing is closing Velcro tabs on shoes. They identify the supplies and equipment needed, which are shoes, socks, and chair. And then they break down the steps of the activity. And you can read those. They begin with prepare the work area, and their number 6 is allowing the child to practice by closing the tabs. In this method of task focused activity analysis, they list the most important performance components. And I'm just going to share that they talked about sensory, motor, cognitive, and psychosocial. Number 1 in each of those areas. So sensory motor was sensory awareness, cognition is level of arousal, and psychosocial is the values. Then in this method, they continue to list, but these are the least important performance components. And clearly, if someone's going to tie their shoes, then oral motor control is not necessarily a requirement. And finally, they look at the environmental context. So, in the physical environment, the activity can be done in the child's room or another room in the home, and the area should be well lighted and the child can sit on the floor. From the social perspective, they say the practitioner and the child will work together until the task is learned. Mother will practice with the child. And finally, in the cultural aspect, in their own culture, people are expected to wear shoes per this task analysis. And finally, they're talking about grading and adapting the activity and safety hazards. Well, first, they say there are no safety hazards involved with this activity of closing Velcro tabs on shoes. When they're talking about grading the activity, and we're going to talk about grading and adapting in a couple of slides, but it's things you're familiar with already. How they could grade it is the method of instruction can vary to accommodate the child's learning need, or the task can be taught using a hand-over-hand method. An adaptation, so making a change, could be D-rings could be placed on the tips or tabs to facilitate grasping the tabs. So this is an example of a task-focused activity analysis. A reminder, your textbook identified 2 forms of task analysis that they were going to focus on or discuss. And the second is the child and family focused activity analyses. Let's think about it. Who are they analyzing? The activity, but for who? The child and the family. So we would expect to see them included in the analysis. So what does this do? It analyzes the actual intervention, and it identifies the child's and family's strengths and weaknesses. So it's very family oriented, maybe used in early intervention and outpatient services. The practitioner plans the activities that are specifically designed to meet the child's therapy objectives. Makes sense. Intervention is going to address their goals. In this plan, they're going to identify the types of materials, supplies, and equipment that'll be needed, where the child should be positioned in the practitioner during intervention. This is what's different in this activity analysis. It documents the expected results or the recommendations, and it includes several activities that may meet the plan's requirement. So let's look on the next slide to see an example from the textbook. If you want to look at it in large format, turn to page 170. In this activity analysis, they identify the setting as home-based and the frequency of OT intervention 5 times a week. So what are they going to be working on? They identify the strengths of the child, which are strong family support, enjoys proprioceptive activities, and enjoys vestibular activities. This makes me think that they're using a sensory integrative approach if they're outlining those sensations, right? Those sensory systems. I don't know, I'm just saying. In the limitations, they're talking about decreased eye contact, delays in fine motor control and gross motor control, and delays with self-care skills. So what is the objective? Here they list the goal for, or the objective for the child, and that is they're going to complete their morning self-care tasks cooperatively without behavioral outbursts within 6 months. And the activities, remember there was more than one activity. The planned activities that they're talking about are hairbrushing, vestibular activities, and dressing activities. And the supplies, they're going to need a hairbrush, a therapy ball, and clothing and shoes. So remember in this plan, they talk about the position of the child. Here they say the child sits on the floor in front of the therapist. In this approach, they also identify the performance results and they comment on that. So the child had difficulty tolerating hair brushing and became agitated with brushing after 3 minutes. And so the recommendations based on the performance results, they're creating some recommendations. And those are to continue with deep pressure hair brushing with a corn brush, allow the child to initiate the hair brushing activity, and limit the activity to 3 to 5 minutes. They then go on, and you can read this, do the same activity analysis, which includes position of the client and practitioner, performance results, and recommendations on sitting on a therapy ball, and the which is the vestibular activity, and finally the dressing activity that you can read those. So what's it going to include? Position, performance results, and recommendations. Why are we talking about activity synthesis? So remember, we're in the section of legitimate tools. What were the legitimate tools? Occupations, purposeful activities, activity analysis, and we just talked about 2 types, task focused and child family focused. And now we're talking about activity synthesis. When you think of synthesis, what comes to your mind? Well, to me, synthesizing, making. So that includes not only making or looking at the activity, but adapting it, grading it, inevitably reconfiguring certain activities so they work for the individual, right? If we're going to have to grade it, we're going to look at what's going to work and what doesn't. Activity synthesis is considered a legitimate tool that's used in practice, and the goal is adapting and grading activities so the individual can participate in occupations in the given contexts. Adaptation is considered one of the steps of activity synthesis, and it includes changing steps during an activity, modifying or changing the sequence of the steps, how the material is presented, the positioning of the child, performing only certain aspects of the activities. And activities can also be adapted by changing the characteristics of the materials that are used, such as their size, shape, texture, or weight. And I think this is pretty self explanatory. But I'm going to read the example from the text about adaptation, just to be clear for you. In the case of a child who's fearful of movement and needs to improve or develop writing reactions, the practitioner may have him or her sit on a therapy ball to elicit the writing reactions. And the text gives photos of this on page 171, figure 1011. Or stand to play while facing a mirror with support from the OT. So remember, what are they doing? They're developing writing reactions. But the child is fearful of movement. So this is where the adaptation is going to occur, right? The practitioner might begin the intervention with a smaller ball that allows the child feet to stay on the ground. And then they might provide very slow, very controlled movements. So in adaptation, the practitioner can make the activity easier or more difficult to find the just right just right challenge for the child. So, adaptation. Gradation is the process of arranging the steps of an activity in a sequential series um, to change or progress an individual. It allows for gradual improvement by increasing the demands at a higher level of performance. Um, we determine as practitioners the extent that we grade an activity based on our clinical reasoning, and a client's performance can change based on how the activity is graded for them. Ultimately, the practitioner, when they adapt and grade the activity, want to move it to its real form. And a couple of examples in the text is when I talked about the child with the writing reactions before, one way to grade that activity is rather than to use a smaller ball, but then also to use something to stabilize the ball so it doesn't roll. So it's grading the activity to make it, to limit the movement of the ball to help the child feel more comfortable while sitting on the ball. That's an example from the text. Another example from the text is, and if you want to see the picture, it's on page 172, I think, figure 1012. It shows a child who's just beginning to eat, and they are finger feeding themselves, um, and the practitioner is fine with that. But then they're going to introduce eventually a utensil so that the child is learning to feed using the utensil. So the child in the image is just learning to pick up the spoon to feed himself. The occupational therapy practitioner allows them to play with the food, but then as the individual performance is improved, then the activity is going to be okay. Now we're going to expect that they're going to bring their food, the spoon, to the mouth or scoop with the spoon. Activity configuration is also part of the activity synthesis, and it's when considering the child's age, their interest, and their abilities for a specific activity. Um, we design activities to the child's goals based on the knowledge of their interests so that it's meaningful and purposeful. Activities are designed to be flexible. We always have to be flexible, particularly in pediatrics. We have to be creative, and we want to make sure it is purposeful to the child and meaningful. In pediatrics, we always consider that activities are age appropriate. And we need to, at this point, when we're designing the activity configuration, consider the method or the media um, specific to remember the frame of reference, or that will meet the needs of the child to be successful in the activity. So, activity configuration, it's a process. I just talked about the child's age. We design the activity. The activities are designed to be flexible. I covered all these things. They're age appropriate while not being overwhelming. And we're going to use methods and media that require the child to be successful. And this is where we consider the, the frame of reference as well. So if we're using a sensory processing, sensory integration frame of reference, we're going to consider using sensory modalities. I just want to add, I don't know why this little speech bubble is, comment bubble is on my slide. There is not a comment for you to click on. I know that part 3 is a little bit long. I am hoping that most of the information in this PowerPoint is a review for you. I do want to let you know I think there are 9 more slides left in this section of the PowerPoint. And here we're talking about therapeutic use of self, and we want to be able to communicate with the child and the child's family. We want to be aware of our own personal feelings. We want to be able to interact and relate with the families. And how do we do that? Well, we need to be mindful of body language. We want to read verbal cues. We want to be caring and not non judgmental. And we want to exercise cultural sensitivity. And this is very important in our practice. And some of the clinical pearls that are in the text that are really nice to consider are examine situations from all angles, because as practitioners, we might have our own perspective or thought, but then when you open your lens and consider what it's like to walk a mile in the family's shoes, you really do learn a lot. Um, the parents or caregivers may not understand the entirety of the diagnosis, but they generally understand their child. And as practitioners, we can learn about the child's strengths and weaknesses during the OT intervention process. Also, be mindful the family knows the child better than you do. And we, on the other hand, can help the parents understand the diagnosis and understand the child's strengths. Um, and we want to involve them in the intervention and problem solving. We also want to make sure that um, we recognize that parents want the most for their child, the best for their child, and we have the role of empowering parents to help them advocate, to help them engage, and help them interact with their child. And making eye contact is at the child's level is really important. You want to look at them, you want them to look at you, you want to make that connection if you can. We want to point out the child's strengths and help the the child in that family situation. We want to gain the child's and the family's trust, and we want to always engage in therapeutic use of self. The chapter talks about the intentional relationship model, but I am not going into detail in this. When we talk about family practice, we'll talk more about that. We've talked about the legitimate tools that we can use in occupational therapy, and now we're still part of the intervention plan, right? We're talking about goal setting. And who ultimately writes the goals is the occupational therapist. However, the occupational therapy assistant collaborates with this. The occupational therapy assistant in goal writing will collaborate with the family. They're going to be part of the development of long-term and short-term goals for any child being treated through the collaborative process. The OTA, the OT, and the family agree on the child's needs as well as the appropriate priorities for intervention. And I'm talking about family here, but when we're working in an educational setting, we can talk about the IEP team, include team members there as well. When everyone is in collaboration and understands, it makes the intervention process more efficient and effective and leads to a better understanding of the child. If the parents don't understand why a goal is written, they're not going to be all about doing it if it involves practice at home. So we need to all be on the same page. And goals are based on the evaluation, the discussion of needs, and they should be realistic goals for the child so that the child can achieve them. Long-term goals tell us what's the outcome of the intervention. So what should the client, the child, achieve after the intervention process? They should be measurable, observable, and clear, written in behavioral terms so that we can identify that there's a change, and they always should be occupation based. Um, Goals need to be very specific and address the problems that have been identified. Long term goals tend to be more general than short term objectives. Why? Because long term goals are the big picture, whereas short term goals are the steps. How do we get there? Short term goals are the steps to the long term goal. So, for example, to be able to um, don and tie my shoes, if that's the big long term goal, by the end of 8 weeks, uh, Johnny will be able to don and tie his shoes independently. That's the big long term goal. Wow. What are the steps to that? Remember, we've just talked about activity analysis. So maybe one of the short term goals is that A, they can independently put on their shoes. B, that they can um, pull the tongue of their shoe, adjust the tongue of their shoe. Then the steps of shoe tying could be broken down. So those are the short term objectives to meet the long term. They describe the skill to be mastered in a relatively short period. So it's going to take a shorter time to be able to learn to put on their shoe than do the entire process of put on their shoe and tie it. The textbook also talks about the acronyms or the methods, abbreviations to understand goal criteria. And there's SMART goals, close goals, ABCD goals, and RUMBA goals. But it's essentially, um, so for an example, an ABCD goal. The includes the audience, the behavior, the condition, and the degree of mastery needed. Each of these criteria have, each letter represents a criteria. I believe you guys are familiar with COAST goals. Um, we'll talk about goals at another time. All the components we have talked about lead us up to treatment implementation, which is also called intervention. This is what we love to do, and it involves working with the system through which the child is receiving therapy. So we plan the sessions, we develop and analyze activities, we grade and adapt the activities as necessary, and why it's geared towards reaching the short term objectives and the long term goals. What is the long term goal? The outcome of intervention, right? That's my target. It's the outcome of intervention. So we've been providing intervention, right? And we get to the point that we need to reevaluate and discharge plan. Are we going to continue with services, or has the child met their goals? How are we going to know? Well, through our documentation is where we document the child's progress. The OTA, the CODA, is always, always, always responsible for reporting any changes to the OTR. So they've achieved the goal, they're not achieved the goal, they haven't been attending sessions, whatever. The the status of the child's performance is on you to let the OTR know, because ultimately it's the OTR who's going to determine discontinuation or continuation of services. The reasons for discontinuation of services vary across systems of care. There are many different reasons. It is always the responsibility of the OTR. The CODA collaborates by reporting the child's progress and making suggestions for future needs. Typically discontinued if the child has met the goal or achieved maximum benefit from OT. Even if a child moves, um, we have to put a discharge plan in place, because if there's a doctor's order and we are treating the child, we have to let them know that we have discontinued services. The reason I'm including this slide is because the text talks about this occupation-centered top-down approach, which is the occupational therapy intervention model, and it's abbreviated OTIPM. And in this approach or model, it's by, I believe it's Gail Fisher, the focus of the evaluation is on the child's occupation. Client factors or components that are interfering with performance are identified, and goals for intervention are based on the overall performance. Practitioners in this model or in any model are encouraged to consider the parental concerns. Why? Because they know the child best, right? Areas of occupational performance. These can include play, social participation. We look at their habits and routines in the top-down approach. The OT is going to interpret the evaluation results and then establish an intervention plan. There is a case study in the book, in the remaining pages of the chapter, that outline how this occupation-centered approach was used. So this chapter is foundational in knowledge, but it's good in that it helps us to apply what you know already to pediatric practice. But generally, we know that the OT process can begin with a referral, then a screening might happen, the evaluation is completed, the OT interprets the results of the evaluation, intervention plan is designed from that. In the intervention plan, we are going to consider the parents' goals, the child's strengths and needs, and more. We're going to use legitimate tools in our intervention process. Those tools of OT practice include therapeutic use of self, activity analysis, purposeful activity, and occupations. When the evaluation is completed, or even before, the OT determines what model of practice they might approach or use to tease out what types of assessment tools they want to use. And if you remember, there was PEO, MOHO, CAWA, and more. The frames of reference that we talked about, and we talked about a number of them, help guide the intervention. Some of those frames of reference might be developmental, rehabilitative, biomechanical, sensory integration, and more. So we did talk and learn and read a lot about the OT process in this chapter. Again, building upon information that you already know. You know how to grade, you know how to think of activity analysis, you know the premise of the OT process, but this was a good refresher. So if I were you and I wanted to do a knowledge check, I'd kind of think, what are some of the models of occupation that could be used in pediatrics, and why are models used? What are some of the frames of reference used in pediatric practice? And what does a frame of reference guide our thinking in? What are the criteria for evaluating a goal or objective? What's the difference between a long-term goal and a short-term goal? And what are the OT tools and how are they used in practice? And ultimately, can you describe the OT process? Describe the steps. When you finish this PowerPoint, take a minute and answer these questions. Thanks for listening, and have a good evening or afternoon or morning. Or if you are like me, maybe it's the middle of the night. Take care. Enjoy.